Hello and welcome to the AHF Podcast. I'm your host, Joe Schwab. Today's guest is someone whose career spans continents, decades, and just about every facet of modern hip and knee surgery. Dr. Michael Solomon is widely recognized as one of Australia's, and probably the world's, leading surgeons in arthritis surgery, joint preservation, and complex hip and knee reconstruction. After graduating from the University of Cape Town, he completed his orthopedic training in Sydney and went on to a traveling fellowship in the United States, focusing on hip and knee replacement as well as hip-preserving techniques. Since then, he's performed more than 10,000 hip and knee replacements, averaging over 900 joint replacements each year. His expertise ranges from anterior approach hip replacement to periacetabular osteotomy, and his clinical work extends across all ages, from pediatric to adult patients, and his contributions to the field include extensive international lecturing, research, and hands-on training for students, registrars, and fellows. But beyond the operating theater, Dr. Solomon is known for his commitment to service. He's operated and taught across the globe, from the U.S. and Canada to South Africa, India, China, and England. And he regularly travels to Tonga to provide voluntary orthopedic care. And if all that wasn't enough, he's actually a pretty good guy. And we're really lucky to have him with us today on the podcast. Dr. Michael Solomon, welcome to the AHF Podcast.
Thank you, Joe. That was quite an introduction, which I feel partly embarrassed about, but I appreciate you introducing me, and I'm very happy to be here.
What initially drew you to pursue orthopedics and in particular hip surgery?
So, as you mentioned in your introduction, I was born in South Africa. I went to medical school in South Africa, and I left shortly afterwards. But my father was an anesthetist, or anesthesiologist, as you would say, and he worked with a remarkable man called Des Dall. And Des, you may remember there was a cable system called the Dall-Miles cable grip. And Des was the Dall of the Dall-Miles, and Miles was Anthony Miles, who was an engineer who subsequently went to Bath in England. But my dad was Des's anesthetist. So I would often, when I was a medical student, I would go to the operating room with my dad. And that way I would meet Des, and he was certainly one of my mentors and inspirations. And that's how I got into thinking orthopedic surgery looks pretty cool.
So did you have mentors along the way who guided you and maybe shape your approach to surgery? Tell me a little bit about that.
So I would recognize three people in my career. I think the first thing to say is, as I said, my dad was an anesthetist, and when I was a medical student, I was kind of thinking, what do I want to do when I finish medical school? And I was working on the process of elimination. And I thought anesthetics was boring, but I'll come back to that later because I think in the end he might have been right. I thought anesthetics was boring. I thought general medicine, I just wasn't cut out to be a physician. Surgery I found interesting, but I figured I wasn't going to become a fine-tuning ophthalmologist or ENT surgeon. But orthopedics was, I thought, really cool. And I remember at medical school, we did our first term in orthopedics. They taught us how to examine a hip, and I thought, this is so straightforward. Look, feel, move. How hard can it be? And I came home that evening and I said to my dad, I found it. I know what I want to be. So actually it was a 6-year course in South Africa, and from that moment onwards, in my third year of a medical school, so this takes me back to 1983, I wanted to be an orthopedic surgeon. That was it. Wow. That was my focus in life. And I was fortunate, again, like I'd mentioned, to have met Des Dall. And then when I immigrated to Australia, I met others, of course. But the two people, aside from Des Dall, who had a profound effect on my career. Des was really right at the beginning, so I was still a medical student. But there were two people. One is an Australian surgeon by the name of John Stephen, who was a pediatric surgeon. He's now retired, pediatric spine surgeon. Just the most amazing mentor, a giant in Australian orthopedics. So being a pediatric orthopedic surgeon, they're sort of a different class, I think, in the sense that they are really patient and family focused more than anything. And John taught me, he broke his finger when he was young, and he had this, he still has it because of course he's still around, but he had this bent fourth finger, and he would talk like this, and you would be in the middle of a 10-hour, as he called it, click clack front and back, spine surgery. He wanted me to be a spine surgeon. I said, no ways. But he would, when there's blood everywhere and the spine monitors are going off, he would say, now listen, don't panic. Just don't panic. Like, I'm the assistant, he's the operator, and he's telling me not to panic. It's easy being an assistant. Anyway, so John was an amazing mentor to me. In fact, one of my, you always think about when you operate, are the early patients you really kind of, a bit nervous about. And John asked me to replace his hip joints. He's got one posterior approach hip and one anterior approach hip, which I'll tell you about later in the interview. But I found that quite a stressful procedure. And in fact, after the first hip replacement, I normally get x-rays and recovery. And he was lying there. I went to see him afterwards, and he was holding up the x-ray, and he said, now listen, he said, it's a bit Russ. I said, what are you talking about? He says, it's varus. You've put it in varus. I said, it's okay. It's a blade stem. It'll work perfectly. And it did. So my three mentors would be Des, John, and of course, my career has been influenced so much in terms of my patient care by none other than Michael Millis from Boston.
Yeah.
Michael, I was fortunate to visit. So when I finished orthopedics in Australia, we were pretty well trained in Australia. Our training scheme is superb. We had a lot of hands-on. We had a lot of cutting experience as trainees, as registrars or residents. And a lot of people didn't even do fellowships in my time, and they went straight into private practice or public practice because they were really reasonably well trained. But I decided to do what I called an over-the-shouldership because I was in a hurry, and I thought, look, I'm going to go 6 months. I'm going to go and spend a month in Chicago with Wayne Proproski, a month in Toronto with Alan Gross. I'm going to go to Exeter for a couple of weeks. And I'm going to go to Boston. They wanted me to do tumors because I was getting a pediatric job as well as an adult job. And I thought, I don't really want to do tumors, but you don't want to upset the people who, like John Stephen, who was one of your mentors. I said, okay, I'll go to Boston. And when I was in Chicago with a month that I spent with Wayne Proproski, one of his fellows had just come back from a course in Toronto, I think it was. It was somewhere in Canada. And he came back and said, I heard this guy talk. His name's Michael Millis. He's changing the shape of hip joints. He's turning hips in dysplastic hips. He's making them look normal. And he's an amazing guy. And you go to Boston, you've got to look this guy up. So I thought, okay, I'll look him up. And in fact, I'll go one better. I mean, the internet was still very in its infancy in that day. We're talking about 1988 now.
Yeah.
89. Well, hang on, wait a minute. I'm losing time. Sorry, we're talking about 1995. Anyhow, I contacted Mike. And I said, look, I'm going to be in Boston. Do you mind if I come to the Children's Hospital and just spend a bit of time looking how you do osteotomies and learning? And he said, with the greatest of pleasure. And so when I was in Boston, I struck up an amazing friendship with Mike. And I went to his clinics. I went to his operating room. I wasn't allowed to scrub because I was only there for 3 months. But his clinics were incredible because Mike has the ability to communicate with patients and patients' parents on a level that is, you have to be there to see it and to appreciate how much he is respected by the patients and their parents. And the clinics would often run late. And everybody would go crazy. Millis is running late again. But it's because he cared and because he spent so much time with people and because he could he really went into what their concerns and worries were. And so I would put Mike as probably my defining mentor, because it's all very well being a good surgeon, but you've got to be a good doctor to patients.
Yeah. So having mentors like that, especially the way you describe your relationship with Michael, you go back to Australia, you're starting your career. So very early on, are you running into challenges or finding that you're encountering mistakes that sort of teach you some important early lessons that maybe you wish you would have learned from your mentors?
It's a great question, Joe. I think you come back from a fellowship and you suddenly think, oh, it's great, I'm going to get into it. And it's like, well, where's all the work? I've been seeing, why are people not sending me patients? Because nobody knows about you. And no matter how good you've been and what you've learned and what skills you learned, you're not getting the work. So in Australia, I think having the ability to be on at a public hospital system, you get a good kickstart because you're on the on-call roster and you start getting some patients and you can start doing things. But at the same time, you kind of recognize that, look, you've gone overseas, you've seen all these joint replacements done, you've learned how to do pelvic osteotomies by watching, but not doing it. And now you want to do them. And so sometimes I think in my early career, I was guilty of spreading myself too thinly to try and get a start. I certainly, I remember when I did my first pelvic osteotomy, there was nobody in Sydney doing pelvic osteotomy surgery. And when I went and spent 3 months in Boston, I would have spent about 2.5 months with Mike Millis. I never scrubbed because I wasn't allowed to scrub. I was watching and I was taking notes. And now I'm suddenly in the thick of it and the sweat's starting to pour. And in fact, with my first osteotomy, I got John Stephen to scrub, who'd never seen one. He'd done Salter osteotomies, but he'd never done Gans osteotomies.
Yeah.
And so I'm just telling him, okay, this is how we got to do it. And he's keeping a calm factor on me. So I think pacing myself was important. And I learned that sometimes the hard way, because in the end, patients value clarity and reassurance and kind of a sense of partnership. And you've got to take away from the fact that you've learned all this stuff. You actually got to think, okay, well, there's a patient on the other side here, and what do I feel I'm skilled at doing, and how can I go into it and help them? And initially I was consulting in about 4 different locations, and I suddenly realized this is crazy. Just slow down, get back to one place, let the patients come to you, start doing your work. If you do good work, word gets out there, and that's what I did.
So how did you balance that, the sort of technical skill that you were honing and your clinical judgment with things like patient communication that you had observed from a Michael Millis, for instance?
Well, I had and I won't call her a mentor, but she's my greatest supporter in life, and that's my wife. And the reason I bring her into this is my wife, Lucille, has bad rheumatoid, and she got rheumatoid. In fact, I think you met her when we were in London together. Yeah. She got rheumatoid when she was 20. Before all these disease-modifying agents were present. And the reason I mention her is because you asked, how do I balance skill and judgment with patient communication? Because Lucille's had multiple operations. Some have been okay and some have been awful in terms of outcomes. And I'd say to her, listen, I think you need to have this done. You need an osteotomy to straighten your leg. I mean, not obviously by me. And she would say to me, but why? I'm not in pain. And I'm thinking ahead, thinking, yes, but I know what's going to happen in years to come because of the angles they are. So clinical judgment should incorporate a really in-depth discussion with patients about their expectations and their fears. Mm-hmm. And I think that's, you need to have a clear plan. When I see a patient, whether they're having surgery or not, they need to leave my consulting room with a clear plan on the problem they came to me with. Mm-hmm. And the plan may not be what they like, but you've got to you've got to give somebody a clear plan, because that instills some confidence in them and saying, okay, he's been, you're not sitting on a fence. Oh, we could do this, we could do that. You're actually saying, look, this is what I think your problem is. This is the way I think you should treat it or should be treated. And I use that sort of the subliminary thinking of the experience that my wife's been through, thinking, is it going to really make a big difference to their lives, what I'm recommending? That's the important.
As you move from being sort of let's just say a competent surgeon to a master surgeon, are there any key habits or routines that you think you developed that sort of made that difference? Something that you could tell sort of younger surgeons or trainees, this was something I really keyed into that took me to that next level.
I think the first thing I would say is don't take shortcuts. No matter how simple it is, stick to the routine. Because if you stick to the routine, you will make less mistakes, because we all make mistakes. I had a resident registrar who I've become very friendly with over the years, an amazing guy, and big guy, like 6'4". And he was in his final year, had finished his exam, and I was doing a hip replacement with him, and I was the junior consultant, and I thought he was going to break the leg. Like, he was powerful, and he was banging away, and I'm thinking, my God, so I said, I should mention his name because only he will know. I said, Al, you gotta feel the tissues here. We don't want to break this femur. You could easily break this femur. I mean, he's so powerful. So this is what I try and teach the younger generation, that surgery, you've got to learn surgical skill, and you've got to feel the tissues and understand that a little old lady with soft bone is not going to be the same as a 50-year-old athlete with strong bone. And you've just got to kind of appreciate that. I think and I'll bring another sort of family member into this, but my son was very fortunate to represent Australia at 2 Olympic Games in the 400 meters. And he started running when he was 16. But when I watched how he approached life and the dedication and the consistency, and he would go to bed early. Oh, I don't go to bed early, but what I'm saying is he tackled his task with a plan, and he stuck to that plan. And I think in orthopedics, even if you're doing something simple, there is a route map, there is a plan, and you tackle the task according to your plan, and you don't take shortcuts. You feel the tissues, you respect your OR team, and you progress for the benefit of the patient. I remember I tell you what else I learned when I was still a registrar, so I was still in training. And I had a lady with an ankle fracture who came in, who needed fixing. And her daughter was a medical student and said, oh, can I come and watch? And I naively said, yeah, sure, no problem. And of course, during the operation, things weren't going smoothly. And I was now sweating a bit because I knew she was in the background watching me fix her grandmother's ankle, bone was as soft as anything. And I'm thinking, this is not good. She should not be in this theater. So that was the first and last time I ever led a relative who happened to be as a medical student into the operating theater. But it's a message to young people that it's all being competent, but you've got to stick to your routine. Don't change your routine.
So, talking about changing routines, at some point in your career, you decided to migrate to anterior approach hip replacement. And you have this history, this legacy of gravitating towards innovation. Talk to me a little bit about that journey. Of course, you mentioned your mentor up front, who you did 2 hip replacements on, 1 posterior, 1 anterior. Tell me a little bit more about that journey.
So, a number of years, in Australia now, probably it's about 15 or 16 years ago. So I was familiar with with the Smith-Peterson approach and with the Gans approach for pelvic osteotomy. So the territory was familiar to it. Mm-hmm. Then in Australia, a company introduced better tools, a leg holder or traction table, whatever you want to call it, and a teaching program. And, I thought I should have a look at this. And so adopting new techniques, I went to listen to a lecture. They had a visiting surgeon who came out, and I thought, yep, this looks interesting. And of course you see slides and it looks easy, but of course it isn't easy when you're starting off. So I made an effort to go and learn from experts. I flew to Europe and visited 2 surgeons there who I thought were superb in their surgeries. I watched some videos. I did some cadaver labs. I had one or two when they were in Australia visit me and scrub with me, so I could say, look, I've been struggling with this particular problem. How do I get around it? So I think when you adopt something new, learn from the experts, watch videos, do cadaver labs. I think and it's something that's current now, because in Australia they've just introduced the ceramic resurfacing as a bearing and an option, and I've been doing resurfacings for many years. But there's a new group of resurfacers who are now wanting to do the ceramics, and we've got a WhatsApp group that incorporates maybe 20 surgeons, which is a fantastic tool because people post what their problems are, and there are senior surgeons and there are junior surgeons on this WhatsApp group, and even the senior surgeons post, and we just, we kind of listen to each other and advice and experience. So I think all these things are critical because we have tools nowadays where we can adopt new technology and learn from our colleagues and peers in a very efficient manner. One of which is a WhatsApp group. So, innovation is good, but innovation without judgment can be dangerous. I did a paper that was published with Richard Des Dall many years ago. We looked at the adoption of the anterior approach in Australia and the learning curve and how many you needed to do to become proficient. And we got to remember that a learning curve comes at a patient's expense, essentially. And one has to be open and upfront and honest with the patient, saying, this is my experience, this is what I've done, I feel comfortable in doing your case. Importantly, you don't start doing an anterior approach on a complex femoral deformity. You start with the simple cases.
Yeah. From your perspective, when you're thinking about patients undergoing hip replacement, are there sort of routine education points for patients that you think are underemphasized preoperatively? So patients undergoing either, let's say, hip replacement or hip preservation, are there things that you feel patients aren't getting routinely educated about that they would benefit from?
I think if I had to summarize that question, patient expectations are the hardest thing for a surgeon and a patient to grasp, because what a patient may be expecting and what you can deliver may be 2 different things. And you need to impart that expectation your knowledge of what you can deliver onto them so they don't cloud their expectations. So I think patient expectations is important. It's easy when you get somebody who can barely walk. They just want to be able to walk. That's easy. But when you get somebody who is very sporty but is getting more pain and wants to do all these things, you've got to temper it a little bit, saying, look, you're getting a joint replacement. It's not your own hip, and this is what you can do, and the majority will be able to do it. So I think patient expectations. I think the other thing, which is a real, it's a disaster if it happens, of course, is a deep joint infection. And I think, even if I tell a patient, look, you've got a 0.3% chance of getting a deep joint infection, we all brush off, I'm not going to get a complication. We always think on the positive side as a patient. But when that patient gets a deep joint infection, and it happens, it is a disaster for everybody in this. It keeps you up at night. It's enormous amount of time trying to address the problem, and all the ramifications, patient's work ramifications, family, etc. So I try and, when I tell them the important complications that can occur, I do emphasize that the deep joint infection is a serious problem. It's rare, but you've got to understand, and we hope it's not going to happen, but if you do get it, it's a long road ahead. So we got to make sure that you are at the point where actually surgery is required. And then on the hip preservation side, again, it comes to expectations a bit, but also recovery. I find, my PAOs take a long time to recover. It's not, you're dealing with generally teenagers and young 20-year-old, mostly females, and they got to understand that this is not an overnight success. They're going to be on crutches for 2 months, maybe a little longer. It's going to be a slow process.
If you were to, because I know we have a number of patients who listen to these types of podcasts. If you were to give advice to a patient who's about to undergo a hip surgery, for instance, if you were to give them one question you could encourage them to ask their surgeon that often gets overlooked, what might that be?
I would be telling a patient the question they need to ask the surgeon is to honestly answer, if they were knowing what they know now about the patient's history and your examination, would you recommend I undergo this operation if I was you or if I was one of your relatives? Because I think if the surgeon is honest, that is the key. Because, I recall a patient who was 97 who couldn't even come to my office. She was in so much pain. Her relatives came to my office. And her name was Fritzi, a wonderful woman. And I said to the relatives, I said, which one's the patient? They had the x-ray. I said, no. They said, it's not us, it's our relative. She can't get out of the apartment. She's in so much pain. At the end of my day, it was a Friday afternoon, I went to her apartment and visited her. And she was this large woman. Her name was Fritzi. And I said, and her arthritis was so bad. She was in agony, constant. A silly doctor had actually decided to get an MRI scan. I mean, the struggle to even get in the scan was crazy. The x-ray showed it all. But the reason I'm telling you the story is that I said to her, Fritzi, you've got two choices. You can have your hip replaced or you can live like this. But nothing else is going to work. Yeah. She said, when can you do it? I phoned my anesthetist. I said, Richard, I've got a lady, she's 97. She's in agony. She needs a hip done. He said, if she's 97, she's indestructible. We did it the following week. She lived to 105, pain-free. And so the point that I'm making is that there are clear times. It's like you think, how do these people put up with it? That you say, I say sometimes, I'm not letting you leave this office until you say, I'm going to have this operation. You can't live life like this, okay? Because they are so bad. But then there are many other patients where you can see they're coping or they're anxious or they're hesitant. Arthritis is not going to kill them. And I say, look, you'll know when you're ready. So come back when you feel you're ready. And yeah.
So we obviously we met at the European Anterior Hip meeting, but now you're also a part of the Anterior Hip Foundation on one of the international committees representing the basically Oceania and the Asia Pacific region. How did you transition, or what made you transition from being, let's say, a learner of anterior approach to a leader in the anterior approach groups that are the advocate groups that are out there basically for anterior approach?
Okay, so I'll start by telling you I'm not a zealot. I don't do 100% anterior approach, okay?
Fair.
And in fact, when I started 16 years ago, I was doing 20% or 30%. Now I reckon I'm probably 85 to 90%, because I do the approach that is best for the patient. Okay. Now I do feel, so the steps I say is, does the approach or technology, does it improve outcomes that matter to the patient? So the anterior approach to me ticks that box, because I think, anterior approach patients recover earlier at the beginning. I don't think it makes a difference when you get to like 4 or 5 months. I think I can get 2 hip replacements walking into my office. One's had anterior, one's had posterior. If I'm blinded, I wouldn't know the difference. But I actually do think the early recovery, it does make a difference. I tell patients, if I have a patient who's morbidly obese, who needs my patient, dear old Fritzi, there was no ways I was going to struggle through an anterior approach with a stomach apron that was coming down almost to the mid-thigh. There was just no point. I could turn her on her side. I could do a posterior approach quite slickly. She just needed to be out of pain. I could have put a doorknob in her hip and she would have been out of pain. That's how much bad her arthritis was. Right. And so she got a posterior approach. And it wasn't about her getting a quicker recovery or getting out of hospital quicker. So and there are patients who've got complex femoral deformities that I won't do an anterior approach on. So I try and take a very sensible approach, but I would do it on the majority. And I would tell patients, if you don't fit my criteria, don't be alarmed. You're still going to get a good outcome in the end because hip replacement's a great operation. You may not recover quite as quickly. I might give you some hip precautions initially, but you will be fine. So it's about educating the patient what's best for them. So, of course, I like the approach, and it is my favorite approach. And, I'm very lucky in part of my operating team to have an amazing rep who effectively runs the table. I do use a leg holder who knows every move I do. And she's, and I work at 3 different hospitals, and she's, I'll give her a shout out. Her name's Bronwyn. She's unbelievable. And has just made me efficient, careful during the surgery. So you need a team. You need a great team. And, so adopting new technology, does it make the patient, is it better for the patient? Does it improve outcomes? Is it consistent for surgeons? Can many surgeons do this? Is this something that's kind of unique that only 1 or 2 skilled people can do? So if you've got something that's good for the patient, and Anterior ticks that box early on, that's reproducible once you've been trained, and it's not complex, and that it helps in post-op outcomes, I think that's why I adopted.
So how did you go from your evaluation of that technique to being part of some of these advocacy groups like the European Anterior Hip Meeting, the Anterior Hip Foundation?
Well, I've got to blame you for the Anterior Hip Foundation because you told me in.
But all right, guilty.
Look, when Anterior Approach started in Australia, it was a little bit of a taboo. There were senior surgeons and of course well-established posterior approach surgeons who I think they were more and to be fair, there was a commercial element in its introduction in Australia. The company that brought it into Australia had a different angle. I went from being a posterior approach guy using a blade stem to an anterior approach guy using a fully coded stem. And not that there was anything wrong with the blade stem or the approach. It's because I thought this technique, because I was familiar with the approach with my osteotomy experience, was a good technique and sounded intuitively the right way to go. But its introduction into Australia was clouded with sort of surgeon. There were some surgeons who went out on a limb to advertise. And in fact, my wife told me one day, I'm sitting on this computer, and she said, "Who's the surgeon?" I said, "What are you talking about? You've never even heard of him." I said, "I know, but in the local newspaper, there's a big advert here that says anterior approach surgery and the happy patients." In Australia, you're not allowed to have patient testimonials on websites or advertising. But this was clear patient testimonials. But the effect was there. This guy had advertised. Suddenly it was out there, and every Tom, Dick, and Harry wanted an anterior approach. It was a bit like when resurfacing started in Australia. You got 90-year-olds turning up wanting a resurfacing because they'd seen something on the television about resurfacing. So it was so the start of anterior approach in Australia was clouded with a bit of commercial advertising, which is we're more of a sort of an English traditionals type orthopedic society. So the beginnings were tough, and everybody, the posterior approach guys, were looking to see where's the problem going to be. And of course, our joint registry, which is a superb document that comes out every year and is now in its 25th year, the joint registry showed that one particular implant had a higher revision rate, and it was for fracture and loosening. And when they delved into it, of course, this was the implant that was primarily used in the anterior approach, because the anterior approach was brought in by a company, and the surgeons using it were going through their learning curve. And as such, the posterior guys were, "Oh, you see, it's a disaster approach. Look, you're going to get the patient's turn, you're going to fracture, you're going to get loose." So that was the start of it all. But actually, the joint registry over time started to show that, in fact, the implant performed just like any other implant after 2 months. So there was a clear learning curve. It wasn't the implant, it was the technique. And once you learned the technique, those problems went away. So now the anterior approach in Australia, we have about 35% are done anterior.
Yeah. Was this the impetus for you doing the learning curve paper that you talked about at the beginning?
Correct. Because what was interesting about that paper, and just, you got to do 50 cases to get skilled. But what we did in that paper is we compared experienced surgeons who started the anterior approach to new surgeons, as in they just come out of their orthopedic residency, who started the anterior approach, and looked at their revision rates. And the joint registry is de-identified. But because I was doing the approach and I knew the company that provided the majority of the implants, we could kind of work out on the joint registry volume based on experience, and then you could see where the learning curve was coming and where the difficulties were. And as people got better and their volume went up, so their revision rate went down. So I went from learning myself to becoming what I felt to be competent in terms of what I was doing, but also being strict with my patient selection, and then teaching the approach. And then I guess, I've given talks in various places about technique and how I do the anterior approach based on experience.
So as you kind of look back at your career, where it's gotten you to so far, is there a piece of advice you wish someone had given you when you were just starting out as a young hip surgeon?
Get well trained. Don't be in a hurry. Treat patients well. Treat staff well. Be generous to your staff. And I'm talking about office staff, operating room staff, reps who help you. Stay humble, because ultimately cream rises to the top. And if you follow basic, just be human. Just have some humanity. And that's something you learn over time, which is your mentors that help you, mold you, and your patients help you mold you, and experience helps you mold you.
And along those lines, what does it mean to you to be a great hip surgeon? If you were to describe a colleague or a mentor or a friend as a great hip surgeon, what does that mean to you?
I think you've got to balance the science and skill of surgery with the humility of patient care. And you've got to treat your team with generosity and respect, because that's, I think if and it can sound cliche-like, but truly we're here for our patients in the end, okay? Yes, we can earn a good living, but actually we're here for our patients. And so you develop skills, you use science, you use innovation, but we've got to impart that on our patients when we feel it is going to be to their benefit. And you've got to listen to your patients. You've got to remain humble, and you can't do it without a team. And you have to respect your team. And I would often do extra lists on a Saturday just to catch up. And the theater, they put up a list. Solomon's doing a list on a Saturday. It gets filled with staff immediately, because we have a fun time in theater. People like coming to the operating room. We play tempo music. We don't play Tchaikovsky. So, when you do a joint replacement thing, it's step, and we stick to the same steps. So they know, this is step 1, step 2. So I tell my anesthetist, put the right music on. We got to keep going.
And given that you've seen sort of the changes or the growth or the evolution, let's say, of medicine in general over your career, is there any advice or encouragement that you'd give to specifically the young surgeons, maybe our learners or registrars who are listening today, who are interested in making an impact to orthopedics?
Yeah, I still think it's a marathon. It's not a sprint. Okay, so don't come out of your fellowship and suddenly say, I'm going to do this, this, and this. Actually, stick to what you've learned well and start doing what you've learned well. And as you develop further skills surgically, you can then branch out with new things. But don't be in a hurry to try different things. Just start off simple. And I'm guilty of not doing this, but it's in hindsight. I look back and I'm thinking, okay, I was in consulting in 4 different locations, and I was on call at 3 different hospitals. Actually, you don't have to do all that. Just stick to what you learned well and do what you learned well, and patients will come because they will tell their friends that you're a good guy, you treated them well, and you did a good operation. And that's how your practice will grow. And I always tell the residents and the new ones, it's going to take 7-8 years to develop a practice. It's not going to happen overnight.
Yeah. Well, I think that's fantastic advice. And Michael, I've really appreciated having you share some of your perspective, share your history, and share your personality with our guests here today on the AHF podcast.
Well, Joe, it's a pleasure. And I have to compliment you, and I hope you put this into this podcast. But your podcasts are fabulous. And it's not just this interview, but I've listened to many, and I've listened to many people you've interviewed, and some of them are really inspiring. And so I'd encourage you to keep going. You've got a wonderful manner of interviewing, your style, and I think it's terrific. And so, congratulations to you, because I think you do a great job.
That's very kind. And of course, you're welcome back on the podcast now at any point, just for having said that. No, Michael, that's excellent. Thank you so much. I look forward. Right. I hope to get to see you in Australia sometime in the near future. And thank you so much for being with us today.
Thank you, Joe. And thank you for everybody who listened in.
And thank you for joining me for this episode of the AHF Podcast. As always, please take a moment to like and subscribe so we can keep the lights on and keep sharing great content just like this. Please also drop any topic ideas or feedback in the comments below. You can find the AHF Podcast on Apple Podcasts, Spotify, or in any of your favorite podcast apps, as well as in video form on YouTube /@Anterior Hip Foundation, all one word. Episodes of the AHF Podcast come out on Fridays. I'm your host, Joe Schwab, asking you to keep those hips and patients happy and healthy.